All right, everyone. Thank you for coming. This is a bit of a sparse crowd, Friday, getting towards the end of the day, last day of conference, but really appreciate everyone being here. This is a topic that's very near and dear to my heart, so I'm glad to have this session to discuss it. So I'm Alex St. John. I'm a researcher at the University of Washington, Seattle. I do research in trauma coagulopathy, and resuscitation. And my motivation for putting this session together was really that I think our understanding of trauma, the pathophysiology of trauma and shock and coagulopathy, and treatments that we can do to address those things has advanced immensely over the last several decades, and especially over the last few years. So my hope here was to try to provide an update on all of the kind of rapidly evolving therapies, diagnostic approaches, and maybe some of the kind of future therapies that might be coming down the development pipeline that we might be seeing in the next 5-10 years. So the talk is entitled The Bleeding Edge, an update on hemorrhage control therapies and trauma. I reached out to what I consider to be kind of a dream team of researchers in this field in emergency medicine. I was delighted that they all said yes. So they're all here. I think that they all have expertise in kind of different aspects of hemorrhage control care and research. And I think we could very easily spend a full day talking about, or more, talking about each of their individual topics. In order to kind of fit into the constraints of this session, I'm hoping to make this more of a kind of question and answer session. And rather than everybody talk about all the kind of nuanced developments in their area, I'd rather kind of open it up to the audience and just let you guys kind of direct it, and we can also just kind of chat because it's a small crowd. What I first want to do is just kind of, I guess what I'll first do is put up our disclosure slide. Then what I want to do is ask each of the panelists to give a kind of brief introduction of who they are and what their area of research is. And then I'll kind of pick things up from there. So Dr. Johnson, do you want to start things off?
Sure. My name is Austin Johnson. I'm at the University of Utah now. Most of my work has been in endovascular resuscitation for a lot around trauma and automation of critical care. Probably 75% trauma, about 25% cardiac arrest.
My name is Kala Freeman from the University of Vermont, and my research is in vascular inflammation and endothelial injury as it contributes to coagulopathy.
I'm Nathan White. I'm at the University of Washington with Alex. My main focus is on fibrinogen biochemistry and engineered therapies for trauma resuscitation.
CJ Winkler. I'm UT Health San Antonio and Texas A&M College Station. I focus on pre-hospital transfusions, so ambulances getting blood into patients pre-hospital.
Frank Guyette. I'm an EMS physician at the University of Pittsburgh, and I'm a co-principal investigator of the LIGHTS Network, linking investigators in trauma and emergency services. We're the DoD's pre-hospital clinical trials network, and we've done studies on plasma, TXA, whole blood.
Great. Thanks. I asked each of our panelists ahead of time to give some kind of topic areas in their field of what they thought might be kind of some of the more exciting developments. And I've put those up here just to kind of summarize, just to maybe spark questions and discussion. But I'd really like to kind of open it up for any questions thank you. Any questions that anybody has in the audience. I'm happy to kind of start things off. So I think a lot of the recent developments in hemorrhage control therapies that we've seen in the literature over the last few years has really been focused on transfusion and the importance of trying to push transfusion to maximize hemostatic benefit of transfusion and really push it to kind of earlier in the pre-hospital, in the patient's care, including the pre-hospital environment. And so the first question, it actually applies to what a lot of you do. But for Dr. Guyette and Dr. Winkler, I think maybe this is kind of the most pertinent for you guys. Just what advances have you seen in recent kind of pre-hospital transfusion in particular? There's been a lot of kind of developments in pre-hospital whole blood, as well as some of the other things that you mentioned, Dr. Guyette. And where do you see that kind of going?
So first, I think based on what we've seen from the PAMPER trial, we have pretty strong evidence that early resuscitation with blood products is better. Some of the subgroup analyses that we did on the PAMPER trial in particular indicated that patients that were resuscitated with crystalloid alone did worse, and those that were transfused with both plasma and packed cell tended to do better. And I think that's interesting because that really sets up CJ and his team, what he's done with whole blood in the community.
Yeah, so way to be modest about the most awesome PAMPER trial. Not, I'm sure, the most awesome name, but PAMPER trial, just amazing trial. If y'all haven't...
That was Jason Sperry, by the way, that named that trial.
It sounds like Dr. Sperry. So if y'all have a chance to read that, just read that. Interestingly, there was another study at the exact same time, the COMBAT trial. Both of these studies use plasma because that's what was available. It just so happened because of the last 2 wars that America was in, we remembered how to use whole blood. That's what comes out of the human factory when someone's in a car wreck, when someone's shot, and that's what comes out when you donate blood. They have to separate it down. I mean, we could back this talk up for someone that knows a little more than me about why we broke whole blood up in the first place into our 3 components. I think I have some various educated guesses, but I don't know for certain. So, once we in San Antonio, which if you don't know, you probably don't, we're Military City, USA. We have the Department of Defense's only level 1 trauma center in the country that treats civilian patients. So I'm able to cross-level a lot of that research that they do, including Dr. Guyette, Dr. Sperry, and we were able to roll out whole blood on ambulances for every patient that is in hemorrhagic shock in San Antonio. For me, it's pretty straightforward. The concept, I think a bigger question for me, and I don't even think anyone in this room would know, but I always get asked, well, does blood save lives on an ambulance? I would back that up a little further, and I'd like someone at this table to tell me where the study is that says blood saves lives in the ER. So really think about that. I know it's so common sense, right? You're transfusing blood. I really have to mention the PROPER trial, right? Because when I was in residency, John Holcomb's paper and the PROPER trial came out, and if you don't know what that is, that's 1-to-1-to-1. Plasma, red blood cells, platelets. And really that is whole blood. But I've always kind of had this mental sticking point where I'm like, well, would it ever be ethical in the ER to compare blood to saline, which is what you're asking EMS to do? Sorry, I just got on a rant. I don't even know if I answered your question, Dr. St. John. I really don't know if there's ever been a study of blood versus plasma or blood versus saline in the ER.
No, and I think your question about whether or not that would be ethical, I think it'd be very challenging to get that past an IRB today.
Yeah, and so that's what makes it difficult pre-hospital. It really does make it difficult pre-hospital to get a control group, because if you're saying something is ethical, we are both ER doctors and EMS doctors, and in our EMS side of the life, I have to tell my medics that they can't transfuse blood because there's not research available. But I'm like, well, how does that research get available for the hospital? I digress.
Those are great thoughts. This also kind of overlaps with Dr. Freeman. Some of your research has been focused really on endothelial cell dysfunction and cell signaling defects and barrier dysfunction of the endothelium. Can you comment at all on kind of where we stand with understanding the effects of transfusion and the effects of plasma transfusion in particular with its effects on the endothelium?
Yeah, sure. And I think one of the big breakthroughs in this was actually the work in Pittsburgh that Frank and Jason Sperry did, looking at the PAMPER study and the sub-analysis in the JCI paper, JC Insight, where you looked at Syndican 1 levels actually go down after plasma transfusion. So you get a reduction in endothelial injury markers in patients that get early plasma. So I think that the one thing that of all the therapies that we know is potentially endothelial protective at this point is early plasma administration.
Yeah, that's a great point. And I think Syndican and thrombomodulin are kind of like the vanguard markers, but there's a lot of complexity in what goes on in the endothelium and the glycocalyx. And what we do know is that saline is really good at stripping the glycocalyx out and probably increasing inflammation and worsening end organ damage, leading to secondary injury from hypoperfusion. So again, more reason why we really don't have equipoise to do a saline versus blood trial.
I guess one other comment I'd add to that is I mentioned Nate Dow, one of the former med students in our lab who is now a resident working with you guys out west. And one of the kind of last experiments still serious he was working on was the effects of low calcium on endothelial injury in the context of trauma. And what we've learned, and I think you guys, it's something that we've been discussing, is that the thresholds for endothelial injury are not the same as the thresholds for coagulopathy when you look at calcium. So you have to drop calcium quite low to actually inhibit your clotting protein enzymatic function. But the even smaller changes in calcium can actually contribute to endothelial injury. So endothelial function requires a normal calcium environment. So I think one of the other areas of interest may be better consideration of calcium and potentially also TXA, also potentially endothelial protective. So there may be strategies to protect the endothelium during transfusion.
Yeah, that's great. Thank you. We can go a little further into this, but first I want to give the audience a chance if there's anyone with any kind of thoughts or questions so far. Don't be shy, it's a small group. Yeah, great point. I want to get into some of the other areas here, but actually, since we just kind of touched on the calcium and TXA topic, I think that's also kind of a really interesting area that's kind of evolving. So I'd love to hear thoughts on, particularly in the pre-hospital environment, what are thresholds for calcium administration and transfusion, massive transfusion, also in the ED, and also TXA. I'd be interested to hear thoughts on pre-hospital TXA.
Yeah, so I guess we start with CRASH 2, we go to CRASH 3, then many other trials, and CRASH 2 was positive. There's some debate about the reproducibility of that study, but just recently in Australia, I think a well-done study, Patches trial, looked at tranexamic acid for those in hemorrhagic shock. And for the true researchers to my left and right, the study was not statistically significant. Sure, it was close though. I think, I can't even remember off the top of my head, the relative risk was 0.6 or 0.7, but the confidence interval slid just over 1. But we still do TXA in San Antonio. We don't do calcium and pre-hospital, and we do TXA pre-hospital. We don't do calcium. I know in vitro it's pretty useful, but the medics are pretty task saturated back there. I think calcium is on the to-do list. Maybe in the next few years. I don't want to make promises, but I think it is possible. But however, when you get to the trauma center, almost always calcium's given. And if I've learned anything, you know, hemorrhagic shock is truly a disease of the glycocalyx. And if that's the test answer going forward for y'all. And we choose to use whole blood, which obviously has all the things we want, coagulation factors, et cetera. It's also just easier to transfuse 1 unit. I just have this to say real quick so I can get it out there. For those of you, you might be a transfusion med doc in the room, but for those of you, most of you are probably ER docs. If you still do plasma, platelets, and red blood cells, after the most serious trauma patient you have in your ER, run over and look if it was given 1-to-1 to 1. I'll bet you $100 it was not. Guess what was given first? The red stuff, because it's red. And then what's given after that, you know, who knows? So I feel TXA and calcium are important, but I just feel like getting the 1-to-1 whole blood being the easiest way to make that happen and not waste the donor's blood. Calcium, I don't know. I'm still, I think it's probably useful to give pre-hospital, but just kind of finding the time.
So CJ, thank you for setting me up. So you know, I think there's an order of operations to this, and the order of operations is definitely to give whole blood first, because you have, as you said, you have all the parts. The problem is that, and if you don't have whole blood, if you have fractionated product, you want to start with plasma so that you're giving clotting factors first. You know, that's anecdotal. That's based on secondary analyses of primary data. So there's associations, but there is not, you know, we can't really infer causality yet. But the other thing I would state is that when you give plasma and when you give whole blood, there's a ton of citrate in it, and it is going to chelate out all the calcium. So about half of our trauma patients are hypocalcemic when they hit the door, and once you've given them blood products, they're all hypocalcemic. And that's going to impair glycocalyx function. It's going to impair the endothelial responsiveness. So if you are having to resort to pressors, particularly you know, as you're trying to get hemorrhage control, then it's going to make them less effective. So definitely, I do think there's a role for calcium. We don't know what that role is, exactly to CJ's point, which is why we're doing the trial. So Cavalier starts this year, and that's going to be pre-hospital calcium with inpatient vasopressin in an umbrella design. So the two can be independent, but there'll be an overlap group so we can see the interaction effects. Also thanks to the DoD for funding that one. But I think the other point, CJ, which I think you made, is that I think we all believe that there's a role for TXA. I think most of, I don't want to presume, but I think most of us think that there is some role for TXA, but the effect size is really small, right? Even in CRASH 2, it's the relative reduction was like 6% mortality, right? So with that small of an effect size, I think, to your point about task saturation, we have to think of an order of operations, right? So refill the tank with real blood, right? Hemorrhage control. Give calcium. Maybe TXA is the last thing that you do in the field, or if it has to wait until you get to the bay, maybe that, so be it. And I apologize, I don't mean to monopolize the conversation.
That's great. So again, before I move on, I want to open it up if anyone else has any thoughts or questions.
For pediatric patients, specifically in the last year, there was a study that did demonstrate that pre-hospital transfusion actually was associated with mortality benefit. I'm in like Baltimore, DC area. We do have a high incidence of penetrating trauma, and I'm just wondering for you all who we do not have access to transfusion in any of our EMS services, what kind of barriers you had to implementing that in your area where you actually have that, because we have such a high rate of penetrating trauma.
Just to make sure I heard, what are the barriers to pre-hospital transfusion, top to bottom?
I mean, just in an area where we really haven't
Well, money. It's really expensive, especially if you have an EMS agency that has a barbecue to pay for their ambulance, which still happens around this country, unfortunately. So each unit of blood is in this country, whole blood, is from $400 to $700 per bag of whole blood. And remember, when I started doing whole blood in San Antonio in 2018, I think there were less than 50 hospitals really using whole blood for trauma in any meaningful way. And in the last 10 years, and Dr. Guyette can correct me, but I bet we have a couple hundred, maybe more, using whole blood. So the whole concept is new. It is really difficult to get, you can't even get platelets on an ambulance. That's why I keep saying whole blood. It's 3-day shelf life. It's not going to happen. So plasma is possible, red blood cells are possible, but whole blood's easiest. So the first thing is Medicare does not reimburse. Insurance companies are wise to us, and they have stopped reimbursing. Over the first 2 or 3 years, we could get a little bit here and there, and they're just not doing it anymore. So you might have saw on the news last night there was a big outcry about no Medicare funding. The other roadblock is going to be your transfusion medicine physician, which is a blood pathologist that focuses on blood. So the transfusion medicine physician, by their nature, they're almost the exact opposite of what an ER doctor is. They're truly the exact opposite of what an EMS doctor is. On a Cartesian personality coordinate, like we're so far apart, we almost come back together on the backside of a 4D model. So I actually have our transfusion medicine doc, both of them, that make our program work in San Antonio, on my list of favorites on my phone. We text, we talk. So money is your first barrier, convincing the transfusion medicine doc that it's okay. Your EMS medical director is probably going to be on board. Your ER docs are probably going to be on board, but you do usually need a surgeon, often a trauma surgeon, that's going to use the blood in the hospital to make it worthwhile. So I have to say this real quick, and I'm also feel like I'm monopolizing time, but to be successful, a successful program does what Dr. Guyette and Dr. Winkler do in their respective programs. We have a rotation system, so we don't waste blood. So we put the blood on the ambulance for 2 weeks, and then it goes to the trauma center at day 14, and they use it within 3 or 4 days. And we have 0% wastage on average. So that is also a selling point, and you have to speak this language to the transfusion medicine physician, because they truly have a lot of FDA rules and AABB regs that they have to follow, that you have no idea what their life is like as an ER doc, frankly. If you've ever wondered why you have to sign 10 things to get blood to save a patient in the ER, it's because they are beholden to federal law to get those things signed. All right, I've monopolized too much time. Those are some of the barriers, money and those doctors in particular. But otherwise, I think that research also, since we're both here, research pre-hospital is really, it's going to take time. Where everybody's working on it. New Orleans, San Antonio, Pennsylvania, Pittsburgh, everybody's working on it.
Can I add one more barrier there?
Yes, please do.
I think, and CJ, you've got a great situation there in Texas, but for like Frank in Pennsylvania with rural patients, or in UW where you've got patients from Alaska, and also in rural Vermont, and we saw from the combat versus pamper analysis that the patients who have the longer transport times get the most bang for the buck. But the ones who have the longest transport times come from the smallest to most rural EMS agencies. So they're the ones who actually need the blood products in those rural outposts. So I think that's another, if you can't do it in Baltimore, how are we going to do it in Alaska and rural Vermont?
Completely agree. One thing we're doing in the nation is PHBTIC, FIBTIC, worst acronym, Pre-Hospital Blood Transfusion Initiative Coalition, to basically talk to our senators, congresspeople, FDA, everybody, to try to get blood on ambulances. In Texas is special in a lot of ways. The best way is that EMS medical directors are not told what to do by the state of Texas. So we are delegated practice, so I could put blood in an EMT basic's hands to transfuse. So we're not beholden to any rules like that. So that does help in Texas. In Texas, we just started a governor's EMS Trauma Advisory Council, and knock on wood, I'm hopeful. Our plan is to have a unit of blood in every county, pre-hospital blood in every county in Texas, all 252 of them, and that's going to take some state funding. But we're working on it. We think we've got the right people in place and the right track. So it's a work in progress. You're at the ground floor just by being here.
I was just going to say, it's a serious equity issue. It's an equity issue, rural versus urban. It's an equity issue in under-resourced communities, definitely in inner-city Baltimore. And whole blood might not be the answer for that. I think freeze-dried plasma, when it finally comes online, will be the answer. It will be a much cheaper solution where you can keep it on a truck, on a shelf for 2 years. It's stable. It's more easily administered. And you're going to get, a significant portion of the benefit just from the FDP. The problem is that it has been in FDA limbo for the last 6 years. But rumor is that we will have a freeze-dried product in the next 18 months. I don't know if anybody on the group knows more than that.
So I will say this real quick to back that up, and then I'm handing my mic away. So in San Antonio Fire Department, the whole truth is we only have 8 units of blood for 1.7 million people. We only have 8 units of blood. 6 of those units are on EMS supervisor vehicles, 2 are on special operations ambulances, and there just isn't any more blood. There's just the donor pool. We have blood on all the ambulances in the rural counties around us. We have blood everywhere. We actually are unable to transfuse every patient that needs blood in San Antonio just because they might be a little far away from us, which creates a natural control group, which I guess that's good for research, but not good for patients. So we would love to have more blood, but I think it's just not possible right now. So freeze-dried plasma, once freeze-dried plasma is approved, honestly, I'm going to start writing a grant. One of my lieutenants and I just 3 days ago were like, let's write a grant to get freeze-dried plasma on every single fire apparatus, squad, bat chief, all 180 units we have in our city, because that is how, and I think it's going to be good for a year and a half on the shelf. So that's a great compromise.
That's great. I want to pivot a little bit and kind of shift over to an area that's been kind of a hot topic for a while now, and that's specifically REBOA. I think that REBOA has been, early on in its conception, it was something that had a lot of, it kind of appealed to everyone's common sense that it just makes sense to have rapid access to go in and halt hemorrhage distal to, your balloon. And for many years, we kind of had very heterogeneous observational data that the trauma community kind of struggled with how to kind of digest it. And most recently, we had the UK REBOA study that showed no effect, no improvement with just kind of standard REBOA techniques in an emergency department setting for trauma patients. That was kind of the first larger prospective trial. But I know that the research field around REBOA and in particular some of the stuff that you're doing, Dr. Johnson, is really looking at trying to find other ways to advance REBOA and find ways that it could be applied and find ways to optimize it and maybe find a better target population. So I'd love to hear your thoughts, Dr. Johnson, on the status of REBOA and what you see coming down the pike.
Sure. I would say it's one of the most polarizing, I'll start off, it's like one of the most polarizing things in trauma right now, and I don't recommend spending like the first 10 years of your career after training working on something that is so polarizing. I guess I'll discuss 2 parts of that question, I guess. I think the clinical data out there is very muddy, whether or not this is our retrospective studies or the recent UK REBOA trial. I'm good friends with most of the people who put together that trial, and there are a lot of issues with that trial, I think. I'm glad it was done, but it really, I mean, if you read the conclusions of that study without actually looking at how the study was done, you'll you will think that the nail is in the coffin, but when you actually look and dig into that study, there are a lot of issues with it. And I think one of the main issues with it is that when that study started, it was still such a new therapy, we didn't know what we were doing. And you'll see in that study that patients were getting REBOAs several hours after their injury because their transport times were so long. And here we are thinking about a therapy that is to rescue a patient who's about to die. Why was it used 2.5 hours later? And there are a lot of issues with it. So if we put that aside and say we still don't know, I do think fundamentally the concept of REBOA made a lot of sense, but people didn't realize how hard it was going to be to do, right? People who have placed a lot of catheters, or if you have a robust ECPR program and you're cannulating a lot of people, you realize it is very difficult to cannulate patients who are about to die. And some people are very good at it if you practice it and you do it all the time. But to unleash it upon the masses is, without adequate training, doesn't work all that well. And, this is being said to, I have a lot of really good friends who are trauma surgeons. But people have different skill sets, and a purely endovascular approach for people who don't do lots and lots of endovascular procedures doesn't always work out really well. So on top of that, you have a difficult procedure, and then you have something that comes with lots and lots of morbidity, right? And that is aortic occlusion is really bad for your life, bad for your health. Nothing likes it other than maybe your heart and your brain, right? So how do you balance that? I think that's been the biggest issue. And we need new therapy. The REBOA as it exists today, I think, doesn't work. Fully occluding the aorta, you really might have 30 minutes of intervention time, and that's not much time. And I think John Holcomb's work, where he actually laid out how long does it take to really take a patient by the time they hit the door to actually be in the abdomen or wherever it is and having hemorrhage control we measure that in hours. We don't measure that in minutes, unfortunately, in the majority of trauma centers in this country. So as it exists now as full aortic occlusion, it doesn't work that well. I've been in the field of what else can we do around this, right? Whether or not that's partial REBOA, whether or not that's intermittent REBOA, what else can we do to potentially that balance between full occlusion? And I think it's coming very slowly. I'll speak briefly. There's a paper that's about to be published from the UK group again. So this is the London HEMS group, where they have been doing partial zone 1 occlusion on the street. This is a feasibility study, and it's a very small sample number, but almost all those patients were either dead on arrival or truly peri-arrest. And they did have survivors who had, up to 2 hours of partial aortic occlusion, and they survived with their kidneys and walked out of the hospital. And these are patients who were dead upon arrival. So I think there's a signal there, but I think what it comes back to is you need the expertise. This is a group who trains weekly, who are practicing this all the time and have become very good at it. So I think there may be a signal there. Like, as someone who has spent the last 10 years of my life looking at this and studying it, and there may be a signal there. And I think in the animal studies, there's a signal of what we can do. Actually implementing that is exceptionally difficult and has quite a ways to go. I guess that's where I would start.
Great summary, thanks. Any other questions on that area right now?
Why not just use mass bands?
Well, they haven't, a couple of things. I mean, they haven't worked.
I'm serious,
Yeah.
I know the studies were
Yeah.
done like 30 years ago and just washed it, but curious.
Can you maybe introduce mass bands also for the audience?
Yeah, so your pressure, like, can you basically just pressurize the lower torso to stop your, to augment perfusion, really? And there are a couple of reasons why I don't think it works. And one is you're only getting the lower limbs. If you look at aortic occlusion in zone 1 versus zone 3, for example, right? And we look at the proximal hemodynamic benefit of where you basically occlude the aorta. If you occlude in zone 3 of the aorta, right? So this is below the renal. So zone 3, just so we remember, is renals down. You see very little proximal hemodynamic benefit from aortic occlusion at that point in time. And And when I think about REBOA, I think about it not only as a hemorrhage control means, but also as a hemodynamic, a means to benefit the hemodynamics that you are trying to achieve. And so if you are bleeding, let's say you have a big liver laceration, and you are trying to compensate for that, right? So you're vasoconstricting as much as you can. The amount of flow you actually have into zone 3 and down in your lower limbs is actually not that much. And we see this too. If we look at your proximal hemodynamic benefit of zone 3 REBOA, it's very minimal, right? And people are actually in shock. Zone 1 is a totally different story because it's so high, you actually have a really big proximal hemodynamic benefit. And so I think it really depends. If you have a really bad, intra-abdominal injury, I don't think the mass pants are providing enough benefit because you don't have that much flow through zone into your legs at that point in time.
What about abdominal aortic turn?
Yeah, I mean, there are tons of, and I actually think there may be some, there probably, it's just because it's easier to place, right? It's like how quickly, a big thing that I think about for all of this is how quickly can your intervention be placed? And I think that's one of the biggest issues with REBOA as we think about it as an endovascular approach. If you're really good, right, you can do it right away. And I've seen it, I've done it. And if you're good, you can have a balloon in a patient's aorta in a matter of minutes. But that is rare, right? Like we don't always have people who are able to do that. And so I think, especially when I think about the pre-hospital setting, is what are these other interventions where you can actually begin to do the same thing that can be applied more rapidly, more easily by potentially out in the field.
Yeah, and I think that's a really interesting question. I think the abdominal tourniquets, so getting direct compression on the abdomen, or junctional tourniquets if you're worried about a pelvic injury or whatnot, there may be some role. The challenge is that the patient selection is really important, and that's another problem with the current REBOA studies, is that the patient selection is all over the map. And I agree. I think there is signal there. I think there is opportunity that we're missing because it is a really challenging technique, and it is really hard to identify exactly the right patient that's going to benefit. And I think my other thought on this is that it reminds me so much of the intraluminal catheters for stroke 20 years ago, right? Like this was the Mercy and the Penumbra and all the failures where we just shattered clot and stroked people out and caused all types of injuries with these devices because most people were putting them in 5 times a year and they weren't using the right patient. It's the exact same story, right? And so I think we need to get right device, right clinician, right patient in order to make this work, and we're not there yet.
Yeah, I think a lot that confounds us, and we seem to always continually fall back into this fallacy for treatment of hemorrhage, especially uncontrolled hemorrhage, is that you can resuscitate your way out of it, which is completely false. 100% of the time, if you resuscitate a patient with uncontrolled, non-compressible hemorrhage, and you prioritize resuscitation, you don't control bleeding, you're going to lose every single time. So the priority is not just, well, I have something I can give this patient to make their blood pressure come up and make them bleed more. The priority needs to be, how do I stop that bleeding, which will then enable my resuscitation to take place. I always say, if I can take my patient from an uncontrolled hemorrhage state to a controlled hemorrhage state, my dream study would be to then infuse cherry Kool-Aid into the vein and see them resuscitate and do just fine, because they would. They'd be great. That's why saline works in controlled hemorrhage, right? It works great in controlled hemorrhage, but that's not what we're dealing with, especially in the pre-hospital setting. So we always have to balance. So it's a mix. It's REBOA. That's definitive hemorrhage control. If you get it above the bleeding wound, right? Maybe a little too definitive in some cases, right? So I think we need to really define what we're going after when we're treating these patients. And it has to be stop the bleeding, stop the bleeding, stop the bleeding needs to be your top 3. Now we get into problems where it's hard enough to stop the bleeding, and our transport times are so long that then they tend to get under-resuscitated at the same time. But we really have to prioritize what we're doing pre-hospital.
That segues really nicely into, I think that a lot of our kind of what we think of as interventions that really promote hemostasis directly have been kind of crude and limited over the last several years. We've, for topical hemostats, we've got quick clot that's been around forever. There's a lot of research in trying to, find newer topical hemostats that are improved and offer a lot of advantage over quick clot. And then for injectable hemostats, I mean, we don't really have any that we use. We've talked about TXA, but mostly we kind of default to blood transfusion because we kind of figure, well, that's what we're normally pumping around in our bodies. It's got to have, whatever good stuff we need. So let's start with that. But as we've, developed a deeper understanding of all of the pathophysiology here, I think what I'm seeing is a lot of really kind of interesting research in more targeted approaches in this area. So, Dr. White, I'd love to hear your thoughts on kind of the current state and future, of what you think might be coming down the pike for injectable hemostats, maybe topical hemostats.
Sure. So my event horizon is a little bit further ahead. So I try to tackle the problems where, what do you do when we don't have blood, when we don't have this or that sort of thing. So in those situations, you really have to emphasize sort of engineer your solutions, and you can only do that with understanding what the real problem is. So what seems to be emerging as the real problem in trauma when we think about coagulopathic bleeding, in that when the blood clotting system falls apart, is it now starting to look like these things are starting to be really driven by inflammation, very early inflammation, either at the endothelium or through leukocyte-induced inflammatory reactions, sepsis-like states, things like that, all these things that happen in trauma. So what seems to be happening is that you're getting very early and very robust inflammatory responses to shock, to injury, and all these things that we're still trying to understand. That'll induce large amounts of oxidative stress. So my particular focus is fibrinogen, which is the best hemostatic protein, by the way. But it's also the most susceptible by far, not just hemostatic protein, but plasma protein to oxidative stress. And we've shown in the lab that putting fibrinogen in proximity with some angry leukocytes oxidizes them immediately, which induces a coagulopathy. And then within about 3 hours, coincidence for TXA, fibrinogen becomes significantly degraded, so to the point where it no longer polymerizes and you can't make clot, so it just falls apart. So I think if we're looking at targeted therapies, next horizon sort of things, we need to start diving into these mechanisms. I think targeting inflammation is going to be one of those huge things where we not only, there's been studies looking at things like antioxidant therapies, anti-inflammatory therapies, but they all happen in the ICU, right? So we need to push those out pre-hospital in the first minutes or hours after these significant injuries. And that's where I think we're going to really start to see progress in terms of new therapies, new things that we can do to actually block and prevent a lot of these problems that we're seeing in the pathophysiology.
And similarly, Dr. Freeman, I'd love to hear your thoughts on therapies that are more targeted to the endothelium. We've talked about plasma and blood product transfusion, but any existing or kind of under development therapies that might be coming to kind of really be more specific towards the endothelium.
Sure. I can tell you the things we're working on, which again is early stage, I'd say basic science, still not translational yet, but one is the histone proteins that are released from Malay cells in trauma are quite toxic to endothelial cells. And there's been quite a bit of evidence to support that. And there's several different ways to scavenge histones out of the blood. And basically any polyanion will do this. Heparin will scavenge histones, but heparin also will contribute to bleeding, so it's maybe not the best polyanion, but we looked at a suramin, which is an old anti-triposomal, an old safe drug that's very effective at scavenging histones. Defibrotide has been shown. There's other custom polyanions. So one idea is, and also antihistone antibodies. So one idea is trying to scavenge some of these trauma factors out of the blood. There's interest in plasmapheresis. Again, not something you can do in the pre-hospital setting though. So maybe for the terminally coagulopathic patient, it'd be a rescue maneuver. But are there things that you can give pre-hospital or early? And one of the ideas that we kicked around and haven't gotten funded yet, but we're working on is to give recombinant proteins instead of as the protein as an mRNA. So if you can target something like, say, an antihistone antibody that we know the peptide, then instead of a $5,000 dose of a drug, you could give a very cheap mRNA vaccine to potentially have sustained release of that protein in the bloodstream for several days. And if that's successful, that would also allow you to potentially prophylactically administer a therapeutic agent before combat for military personnel or others at high risk. The other target we're looking at is the 3K3 activated protein C. It's like Xyrus, but doesn't have the anticoagulant effect. But that's also been mired in some controversy recently. So I think I'll just comment one other point. I think that these type of targeted therapies, some of them are attractive that you could give them pre-hospital, and you could have a shock drug that you could just give somebody in the ambulance in the advanced setting. But the other, I think, important way we might move the field forward is by better identification of which patients need which therapy. Particularly TXA, I know, has been discussed. If people don't have fibrinolysis, do they need TXA? Are you going to push them into a shutdown? Is that, maybe you guys can comment if you believe this idea of fibrinolysis shutdown, and is there a risk of TXA being given just systematically?
Yeah, so it's my opinion that fibrinolytic shutdown doesn't exist in the first 3 to 6 hours after trauma. It's a later event. It does exist. It's real. It's just not relevant during the bleeding phase of trauma, which is about 3 hours, 6 hours. So either they're alive and they've transitioned into a shutdown state, or they're dead. And there's only one of those two outcomes usually.
I mean, how many of you guys are doing TEG-based transfusions? Is this something that is common or not?
Not pre-hospital. But that's a great point, right? I think the reason that whole blood is such an attractive option is that it doesn't matter, right? Because you have all the material. You're going to be attacking all the different elements of coagulopathy, particularly if you're giving it in conjunction with calcium and whatnot. So as a pre-hospital solution, that's probably the best tool that we have right now. But, and I agree, I mean, I think TXA, we don't fully understand the mechanism, right? I mean, certainly there's the fibrinolytic inhibition, but like the other question is, are there anti-inflammatory components to it? Is it helping the glycocalyx? We don't know. We have some assumptions, and I'd love to talk about some of our STAMP data looking at the syndican and thrombomodulin markers, but I don't know if you have better thoughts.
Yeah. So I do have a couple of thoughts on TXA. TXA I love it. I would give it to everybody. Just because I haven't seen any real sort of risk signal from it, really, to tell you the truth, in any of the thousands of patients that have been studied. It doesn't seem like a risky drug at all, and it helps a little bit. TXA, a couple of things to remember about TXA. TXA blocks the spot that plasminogen and plasmin and TPA land on fibrin. That's all it does. It doesn't block the active site. So there's actually a piece on fibrinogen called the A-alpha-C domain that is cleaved preferentially by plasmin very early on. It's the first cleavage point because it's very soluble. It's out in the breeze flopping around. And TXA does not block that, so at all. Because that requires a landing site, which is on the different fibrin chains. So you will still get fibrinogen lysis in the presence of TXA. The other thing that TXA can do is through these different pathways is it can actually activate other coagulation factors through its inhibition of plasmin. So plasmin will go and chew up anything that it comes into contact with, including things like factor 12 and all these other things. But TXA can block those secondary activities, so it can actually help you to maintain clotting through different pathways. And of course, there's hypothesis that there's certain interactions in the brain and that sort of thing, where it's also can be protective. So TXA, I like it personally. I think there's a lot more to know about it, especially.
It looks like we're running really short on time. I wonder if we can squeeze in if there's any burning questions in the audience. I've kind of monopolized the questions, but if there are any other questions in the audience, please fire away. Yeah, what's that?
So,
I know a question you want to ask. The right patient, resuscitation, you really should have blood in your ER. You should have a blood fridge available for emergency transfusions in your ER. The Dr. Cotton study, and I'm sure many others, basically said the sooner you can get blood into the hemorrhagic shock patient, the better. So it's nice that I have it on the ambulance and we can give it in 30 seconds, but you should also have it that readily available in the ER. And just because I want to say this in this group, that on Friday in San Antonio, we stopped doing chest compressions in traumatic circulatory arrest patients until we can do control hemorrhage. So until we control hemorrhage, we can do some respiratory things like pleural decompression, et cetera, and we can transfuse blood, and then we'll do chest compressions potentially.
Great. Any other questions? I wish we could, oh, go ahead.
I can just say we did take, as part of our research program for trauma patients for many years, but we do not use it clinically in our institution for transfusion therapy. We have ratio-based transfusions. So it was always a paradox to me that our collaborators at Pittsburgh and Denver were using TEG to guide transfusion, but we in Vermont were not. So I noted that paradox, and I think it still exists. But I don't know if there's, you guys can comment further.
Yeah, we don't use TEG either. We have an emergency hemorrhage panel that we get similar type information back just on your basic clotting assays that you do PT, PTT, fibrinogen, platelet count, so we get it back really fast. So that's our kind of TEG that we use.
Yeah, I think that's a great point. I think for initial resuscitation, TEG doesn't matter, right? Like, person is leaking blood, put the blood back in. And I think it's really cool that you guys could watch it in the trauma bay, but I would never make that decision in the trauma bay. Like, you should be in the OR if you're having to make that decision. And in the OR after your first MTP, maybe that's when you should be looking at the TEG. Your vasopressin question, I think, is again fascinating, because vasopressin, again, we don't fully understand how all its mechanisms of action, right? We think it may have an anti-inflammatory role. We think it may have an endovascular role, or sorry, not an endothelial role. But we also know that it's a very powerful way to get your systemic vascular resistance up. Based on the study out of Penn, it may be blood sparing, but I don't really know if that's the true benefit. And that's also why that's going to be part of our future study.
Yeah, I think just real quick, one of the main use for TEG is to answer the question of why is my patient still bleeding, not not am I doing so. It's if you have a patient that is still bleeding and they have an abnormal TEG, then you have something to fix, right? If you have a patient that's still bleeding and they have a normal TEG, then you got to look at your surgeon.
That's great. I think we're out of time, so I really wish I feel like we could make a whole conference out of exploring these topics a little more, but we have to cut it off, unfortunately. I really want to thank all of the panelists for being here. Really appreciate all your expertise and input here, and thank you very much.